So the Evolution registry design is really an all-comers registry for left atrial appendage closure using the WATCHMAN device. The Protect AF went through and really regimented warfarin up front, followed by TEE, followed by aspirin Plavix for 4.5 months, followed by just aspirin alone. The Evolution registry was an all-comers registry for different anatomies and all that put together, but in addition there was an all-comers registry for the type of anticoagulation. One of the biggest things, for example, in this registry is that 60% of the patients received DAPT for a period of time, which is very different than what we would have expected in another population overall. Now, the big thing to also remember here is that this DAPT idea is not new. The ASAP trial already went through the DAPT data and showed that this was reasonable. The Evolution trial adds on to that, which is one of the main points in this paper. So the aside from the DAPT that we just talked about a second ago, overall the stroke risk came down to 1.4%. That by far and away is one of the best key findings of this paper, is that this is not just better than Coumadin, it also is very similar to, for example, what apixaban would have done in the similar patient population and brought down the risk of stroke down to that level. We do know that the risk of any serious adverse events, which was published a while ago in the 7-day period, this was at 2.8%, which is much better than the Prevail, than the CAP, and then also Protect AF, which shows the natural evolution to you be ironic for a second, of the learning curve. I think the biggest thing that we're able to say is that left atrial appendage is not just here to stay, it's also gotten better and better. The biggest thing to, I think, take about is that the reason that a left atrial appendage was positive was that it was positive because the ischemic burden was roughly the same when you were on a WATCHMAN or whether you were on warfarin. But in addition to this, the safety overall from a bleeding perspective was much better with the WATCHMAN device than being on warfarin. Now, that was back in the Protect AF when the original issue with adverse events was around 10%. Now, if that drops down to 2%, what you actually will see is that the curves will separate much earlier and they'll separate for longer. At some point, these curves will plateau, but you'll have even more evidence that it is positive for, positive for cardiovascular mortality, positive for all-cause mortality, if that trial was redone today in 2017. But unfortunately, I don't think anybody's going to pay or need to pay for that to happen. I think the biggest thing that we need to look out for is, yes, we do have this going forward. We can consider this with NOACs, for example. That's one aspect. The second aspect is, what's the utility of alternative imaging modalities? I think this is the biggest untapped need within left atrial appendage closure. Yes, within some time period, we'll have 5-year results, 10-year results, and that's all very important. We're not there yet in terms of the, we have 5-year results, but I mean the 10-year results or 20-year results. It's going to take some time. But what do we need now to be able to make this procedure safer and faster? I think that's where we're at. So we already have some level of safety with TEE, but TEE requires general anesthesia for the vast majority of people. It requires oftentimes an anesthesiologist. It adds other personnel and cost to the room. What about a strategy of using CT scan instead of TEE? How good is that? What are their limitations? What's our best protocol for this? And what about using ICE during the procedure itself? So there's a lot of work being done with 2D ICE as well as also 3D ICE to move that forward. Where do you get the measurements? What do you call the major diameter? How do you make sure your transeptal puncture goes okay? How do you show that it fits the PASS criteria, for example? And then at the end of it, how do you make sure that you recognize the complication and then manage the complication? So all these things will change, in my mind, the way that left atrial appendage closure is going, similar to how TAVI has changed. TAVI started off with a general anesthesia setup. It started off with a radial line. It started off with a swan. It started off with transesophageal echo. And now we're moving into conscious or local anesthesia, number one. Number two is we're using transthoracic echo. And number three, the patients are going to the floor and not going to a post-anesthesia care unit or to an intensive care unit. This has had vast differences in that overall. Now, between US and Europe, the cost of an ICE catheter is seen as a very different thing on both sides of the pond. In the US, there's a much higher use of ICE for many reasons. In Europe, it's not so much the case. So I think in the United States, this will potentially change, and a lot of the research may come out of the US for this. On the European side, what I see is that this may work, but overall it needs to really be protocolized, move forward, and really shown to be cost effective because of the way that the different healthcare systems are set up.